In this video, I'll be talking about the benefits of Miochol in complex cases. And by complex cases, I mean lenses that needed to be put in the sulcus, or if you have to do a sutured or a flange fixated IOL. And so the three main benefits I want to highlight is number one, it helps you recognize vitreous at the end of the case. It reduces the incidence of pupillary capture, and it also helps in lowering IOP. So let's go into topic number one. Now, if you're dealing with a complex case, you're likely going to be dealing with entangled vitreous. Vitreous can prolapse forward. If you don't stain for vitreous, which you should always do, but if you don't, or even if you did, it's always good to place Miochol at the end of the case. What Miochol will do is it will constrict the dilated pupil. Now, if there is no vitreous, your pupil will go from here to here. That's normal. But if there is prolapse vitreous, you're going to see peaking of the pupil. The pupil will look irregular and will actually point to where the potentially prolapsed vitreous is. So if you place Miochol and you see that this is it ends up being a normal sized smaller pupil, you know you're okay, but it really gives you a sense of whether there's anything else going on that needs cleaning up. And so if you see that, you need to do a more thorough vitrectomy to release any potential adhesions. This is so important because this can cause endophthalmitis if there's any prolapse that's sticking out to the wound. Number two is reducing pupillary capture. So what do I mean by that? Well, this is a three-piece IOL was placed in the sulcus, or this also applies to the Yamani technique. By putting Miochol, you're constricting the pupil down. It reduces the incidence of the actual optic coming forward because it's not in the bag. It's coming forward and being captured by the optic. And this can also happen in the Yamani technique. So how do we prevent that? Well, it's obviously the chances of the optic coming forward is much higher if the pupil is very well dilated. So place Miochol at the end, bring the pupil down. Now it's very difficult for the optic to prolapse through a smaller pupil. In the Yamani technique as well, what's helpful is doing a peripheral iridotomy, but that would be the second benefit. The third benefit is when you're dealing with complex cases, you use a lot of dispersive viscoelastic to keep the keep the vitreous back. And often you're going to deal with high IOP afterwards due to the presence of vitreous, due to the copious amount of dispersive viscoelastic. And you'll give the patient Diamox afterwards, but Diamox only reduces the amount of fluid production in the eye. You likely will have some retained viscoelastic. And by placing Miochol, you're also going to help aid in lowering IOP because it works on the trabecular meshwork. And so, in summary, these are the three main points I want to highlight when dealing with complex cases. That's a case where you had to place a three-piece lens in the sulcus, or if you're doing flange or suture fixation, you're going to deal with vitreous, place Miochol at the end, look for any peaking. Number two, with the Yamani technique or even sulcus fixation, there's a chance of pupillary capture. And this is particularly true with the Yamani technique. You don't want to see the patient a day or two later and see that the optic is now captured by the pupil. You're going to have to go back to the operating room for that. And number three, in complex cases, you're dealing with a lot of viscoelastic, a lot of vitreous. Yes, Diamox will help in reducing production, but you also want to improve the outflow tract of your viscoelastic. Always do a copious amount of viscoelastic removal, but this will also reduce IOP post-operatively. Hope you found this to be useful, and thanks for watching.